I don't think there's really any way for me or any one person to talk about the accomplishments of SHM and hospital medicine over the past year. So what I wanted to do is to share just a couple of vignettes that merely give you a flavor for what the medical society has accomplished over the last year. And it's a story that I'm going to call Big Britches and Breakthroughs. And so let me just say that SHM is much bigger and grander than we would have expected. So let me describe what that looks like for SHM. And as far as the policy and advocacy agenda has gone for SHM, it's just been an unbelievable year. It's been tremendous in terms of our accomplishments and our positioning in the policy and advocacy arena. And let me start with Congress. Not only were your efforts instrumental in stopping a 10.1% cut of Medicare fees, we were able to help lobby for a 0.5% increase through June 30th. And of course, my announcement yesterday to help continue to drive the advocacy effort on our behalf to prevent a 10.6% reduction on July 1st. That's what SHM has helped to engineer and make much easier for all of us to be advocates. And in 2000, just to give you a sense, in 2006, SHM members generated, as far as we can count, 388 letters to Capitol Hill lawmakers. And that's in contrast to nearly 1,400 in 2007. And I can tell you that we didn't have a 400% increase in membership, but this really came from SHM engineering efforts to make it easy to do the right thing. And so I would expect that number to keep going up further and further. So we've really done great things in terms of working with Congress. MedPAC, which is the advisory body to CMS on Medicare payments, have been a number of issues on hospitalists in the last year. In a recent MedPAC meeting, a discussion came up where MedPAC was discussing how hospitalists would drive up utilization and drive up admissions to the hospital. And it was simply because they didn't understand the role of the hospitalist in the hospital. And so having SHM members at that MedPAC meeting, we were able to alter the transcript and set the course right in terms of what hospitalists actually do instead of driving up utilization and admissions. But MedPAC is going to be discussing and is discussing the bundling of payments, single payments to hospitals and physicians in one package, and then letting those two entities sort it out in terms of how the dollars get allocated. They're thinking about hospital-physician relationships, and they're also really looking at driving payments to hospitals that have better readmission rates and penalizing those that have higher readmission rates. So our presence in Congress and with MedPAC will continue to be important and certainly have been thus far. Let me make a mention about the Senate Roundtable. And many of you may have seen mention that we were involved and asked to sit on a Senate Finance Committee roundtable on value-based purchasing for healthcare. And value-based purchasing is really code for pay for performance, but SHM was one of two physician organizations that were invited to the table. The other one was the American College of Surgeons. But other members of the roundtable included the National Quality Forum, AARP, Blue Cross Blue Shield, Premier, the American Hospital Association, the American Nurses Association, and others. But SHM, having representation at that table, we were able to put our position forward on pay for performance in support of that model and in support of the reforms that are so badly needed in terms of harmonizing measures and not having separate measurements for hospitals and separate for physicians and separate for nurses, but to bring those together and make sense of them and to make them more integrated and more appropriate, to drive more towards outcome measures as opposed to simple process measures, and to include the consideration of efficiency measures. And in my testimony before the roundtable, I also put before them looking at transitions of care in terms of the best way to bring all key stakeholders to the table in terms of how do patients move through our system, not just what happens to them within any given segment of the system. So we're hopeful that both on an outcomes basis as well as looking more closely at transitions of care for performance measures, we'll make some inroads with both the Senate committee and its advice to Medicare on building a better payment system. I think the other key thing to take away from that roundtable was that there were folks a lot more senior than me in the room, and those that have been in healthcare for 30 or more years. And collectively, at the end of the session, there was a feeling that this represented a true landmark event in terms of healthcare reform and getting a payment structure that aligns quality of service rather than volume of services as well it should be. And finally, the involvement of SHM with the AMA Physician Consortium, or the PCPI as it's known, and the Physician Quality Reporting Initiative. The brief story there is that SHM and hospitalists were at risk of losing the ability to report on quality measures related to inpatient care of heart failure. And what is the number one DRG in just about all of our hospitals? It's heart failure. It's a core measure. It's an established metric that so many of us are charged to improve. But we were at risk of not being able to report or receive incentives for ACE or ARB for LV dysfunction, oral antiplatelet therapy for coronary disease, or beta blocker for previous MI. And because of our advocacy efforts and the strength of people in this room, we were able to push forward an appropriate advocacy for the AMA, who ruled in our favor, and we're now not only able to report those, but to have them included in the 2008 measures for reporting and for quality incentives. I think the moral of all this is that our involvement in advocacy and working with organizations that are key to pushing forward key policy and reforms is going to be critical, and that this has given SHM very high visibility in the measurement stakeholder groups like CMS, like NQF, which raises our credibility and our influence as a professional society. Let me mention also that bigger than expected, things that we're taking on in the last year and moving forward. Transitions of care, as I mentioned, not only is it a potential quality metric that may be considered in the future for performance reporting, but there are many activities that SHM is involved in terms of advancing the quality of transitions of care. And we're not only intimately concerned with the care that happens within the four walls of the hospital, but also care that happens prior to the patient's arrival and certainly after the patient leaves the hospital. And so these are just a few of the initiatives that are going on to help promote transitions of care. The Stepping Up to the Plate Alliance that is championed through the ABIM Foundation, SHM is a key member of that alliance. There is a Transitions of Care Consensus Group comprised of ACP, SHM, and SGIM. There is a coalition, the National Transitions of Care Coalition, led by the Case Management Society of America, so we certainly have more than just physicians thinking about this, but SHM has been intimate to that. A Hartford grant that we are working on in terms of putting together the high-quality discharge process for adults and putting together a toolkit that all of you would eventually be able to use in terms of championing improved transitions of care for older adults. SHM has put together a white paper on handoffs within the hospital that should be coming to a journal near you soon. And finally, I mentioned the AMA consortium, but the AMA has gone so far as to ask SHM to develop 6 or 8 quality measures related to transitions of care that would then be pushed through to the National Quality Forum and then fall into a reporting and an eventual incentive alignment, much in the way that ACE inhibitors for heart failure is concerned. So SHM is championing the performance measure development for this process. So I think a real groundbreaking strides in terms of transitions of care. Just as an example of the leadership, the commitment to the care continuum and the commitment to our patients. Now let me move on from big britches to some other breakthroughs, and this really is something I think that is reflective of the two plenary sessions that we heard both yesterday morning from Don Berwick and this morning from Ian Morrison, and breakthroughs again in terms of what are some ways that we can break out of the old model? What are some ways that we can actually move forward from something that we know is badly broken? And how can we ever think about delivering on a triple aim? How could we ever think about building a better chassis instead of just pimping the car that we're in? If you want to move something from where it is today, you need to think in a bit of a creative light, and so I think that's what SHM is trying to do in terms of breaking out of a chassis that is broken, in terms of being able to deliver on the promise of hospital medicine. And I heard that mentioned at the panel yesterday morning, the promise of hospital medicine. How are we doing on quality? Well, it's more promise than delivery. Well, I think the promise goes much further than the care that's delivered within the hospital. It certainly relates to the continuum. So how does that all fit together? Well, the first, I hope I've made an argument that policy matters, that our efforts in terms of policy and advocacy matter tremendously. But the new idea that we're moving forward with is something that we're calling the Hospital Care Collaborative. And the Hospital Care Collaborative is a way of I think, helping to better support, better engineer, better break through this whole idea of teamwork. And we know that there's more that goes into care than just physicians in the hospital, and it involves nursing, it involves social work, it involves many others. And to deliver on that promise of care within the hospital and beyond, SHM is moving forward with what we're calling a Hospital Care Collaborative that will include key organizations in nursing, the American Association of Critical Care Nurses, with health system pharmacists, the ASHSP, the Case Management Society of America, the National Association of Social Work, and others. And the recognition is really that healthcare improvement is a team sport, and that we need to be not only responsive to regulatory and quality imperatives, but proactive in terms of those performance standards, and looking to develop new models of care instead of just trying to tweak the old ones. And moving forward in terms of becoming an active promoter, not just a passive recipient of those imperatives, and looking at those new models of team care and being able to promote that widely. I know that there have been many innovations at a local institutional level, but SHM is looking to carry that forward in terms of a broader organizational and collaborative model that we hope will help serve as an example and as a support network for all of you in the room and well beyond. And the final is that breaking through for reform. How did Ian Morrison finish up his speech? How did Don finish up his speech? Well, they basically said it all comes down to leadership. And the leadership that comes from each of you in this room, and SHM wants to be positioned clearly to help support in developing leaders, nurturing them, and giving them a network where they can derive both strength, energy, new ideas, and the skills necessary to move this tremendously hard work forward. So SHM is committed to leadership development. We have a several-year plan for refining the core competencies in leadership for hospital medicine, plans for developing a mentoring program, plans for offering coaching to our leaders, plans for simulations and case-based practices, and eventually developing a leadership certification program within SHM, all of those to support not only our medical directors, but all of you that are aspiring to do the work of quality, of patient-centered care, and of delivering on the promise of hospital medicine. And I'll sum it up by just calling the question, healthcare reform, who's going to lead it? And as Ian pointed out, physicians have traditionally taken a back seat in terms of leading healthcare reform, but I'd like to offer something a little bit different. And I'll just leave a thought that came from, not from me, but from Samuel Thier, who was the former president of the Institute of Medicine. And he said very eloquently, in choosing the possible leaders to reform the U.S. healthcare system, a compelling argument can be made that physicians should lead, particularly in defining effective and appropriate care. Defining what does and does not work in medicine is a professional responsibility of the highest order. With that, I'll say thank you. It's been a tremendous year. I've enjoyed so much providing service in this role and look forward to many more years in serving in other capacities as long as SHM will have me.